Good afternoon, everyone. Welcome to the final webinar in our September Symposium series on cognition and Parkinson's. Today, speech-language pathologist Jamie Russell will be speaking on language impairment as it relates to cognitive decline. My name is Alana Dillon. I'm an Education and Support Services Coordinator at Parkinson Society BC, and I'll be facilitating our webinar today. Before I introduce Jamie, I'd like to go through a few housekeeping items. First, I want to let you know that we are recording this webinar and it, along with the presentation slides, will be available on our website. And your videos are turned off and mics muted to prevent any interference in the presentation today. And secondly, you will see a chat box at the right-hand side of your screen. Feel free to use this chat box during the webinar to make any comments or questions on today's presentation topic. The chat box is sometimes at the bottom bar. There will be a chat bubble icon. If you click on that, the chat box will expand. And Jamie will address questions at the very end of her presentation. And finally, to optimize your experience with this webinar, please ensure that you adjust your speaker volume both on your computer as well as on your actual speakers so that you can hear the webinar well. And if you are experiencing audio issues, please ensure that you haven't pressed your mute button on your keyboard. If you experience audio or video freezing or interference, please refresh your browser. That usually resolves the issue. And if that doesn't work, please log out and log back in. I'd now like to introduce Jamie Russell. Jamie Russell is a speech-language pathologist. She completed her Master of Science Applied at McGill University in Montreal, Quebec City, and maintains registration with the College of Speech and Hearing Health Professionals of BC and Speech and Audiology Canada. She has a special interest in Parkinson's disease and Parkinson's plus conditions, and regularly completes continuing education in movement disorders. She is LSVT certified. Jamie works for Fraser Health and splits her time between the Jim Pattison Outpatient Care and Surgery Center and Surrey Memorial Hospital. She's thrilled to partner with the Parkinson Society of BC on their mission to provide education and support to the local community living with Parkinson's. Jamie, welcome and thank you for presenting for us today. And I will pass it over to you now.
Thanks, Alana. Hello, everybody. I hope that you're doing well on this gray but not yet rainy Monday. Thanks for joining me. So let's get started. Today's topic is communication, swallowing, and cognition. And there we go. Let's go through our outline. So our outline for today is to start first with just a brief introduction to speech-language pathology and the areas that we cover. I will do some definitions so that we're all on the same page. We'll really briefly talk about Parkinson's disease and what that means, because I know that you have gotten a lot of that information from past talks. Then we'll discuss communication and swallowing changes in Parkinson's. We'll look at cognition and the possible impact that it can have on communication and swallowing. And then we will get to the really good stuff, which are strategies for communication, some strategies for swallowing, and then functional strategies for daily life. Okay, so speech-language pathology is actually a really, really broad field. So we look at communication, we look at swallowing, and then we also look at what we call cognitive communication. So if we start with communication, first, it's important to note that speech pathologists don't just work with kids. So lots of times when people think of SLPs, they think of speech therapists working with kids who are having difficulty saying certain sounds like R's or with stuttering. But the truth of the matter is that speech pathologists work across the lifespan, from the NICU, so with our little tiny wee ones, into the schools, and then even with adults and seniors. So we look at both developmental disorders as well as acquired disorders. So changes to communication, swallowing, or cognitive communication that can be as a result of something acquired. So communication itself can be broken down into lots of bits and pieces. So first we can look at speech, which is things like articulation, so how we produce sounds. We can look at phonology, which is how we organize those sounds in a language. We look at motor speech, which is basically the motor process of speech. So how we put together sounds into words, our rate of speech, how our voice plays into that. And motor speech is a relevant one for Parkinson's. We look at voice and resonance. So your quality of voice, for example, and then resonance being things like nasality, or if your soft palate is doing its job to block off your nasal cavity when you're saying oral sounds, or if it's down when you're having nasal sounds like an M, N, those kinds of sounds. We also look at fluency. So that's the aforementioned stuttering. We do look at language, which can be broken down into verbal expression and then comprehension. So when we talk about verbal expression, we're really looking at things like word finding. We're looking at putting words together into phrases, into sentences when we're speaking or giving a presentation. And then we can also look at comprehension, which is our understanding. Okay, so are you able to follow what is said? Follow what's on a TV show, a movie, things like that. It's important to note that language refers to both oral languages, so spoken languages, or more nonverbal languages, so something like sign language. We also look at written expression, so not the motor component, so how we write, that's OTs, but we do look at spelling, putting letters together to form words, going all the way from simple list taking to writing an essay. We look at reading comprehension, which is literacy, right? So decoding what you read, processing letters, sounds, and then understanding what you read. And then finally, we look at cognitive communication. So cognitive communication can be things like social communication, how you are in a social situation, since we speak differently when we're talking to somebody one-on-one that we know really well versus giving a presentation or even talking to your doctor. We also look at how cognitive functions impact language, okay? So how cognition affects what we say and how we say it, which we'll chat about in a little bit. Okay, lots of people are surprised to find that speech pathologists also look at swallowing and feeding. So again, across the lifespan. Swallowing can be split up into 3 phases. So the oral phase, which is that first phase of swallowing and includes things like getting food and liquid into your mouth, keeping it in your mouth, right? Not having it fall out, moving it around your mouth. So tongue movements, as well as chewing, so mastication. The second phase of swallowing we call the pharyngeal phase, and that's after you started your swallow. So it's getting your swallow started, making sure that you are protecting your airway, since when we eat and drink, we don't want things to go the wrong way towards your lungs. We want them to go down your throat to your esophagus and your stomach. And then also looking at, is food being cleared in the way that it should from your mouth and your throat, and getting its or making its way down to your esophagus, which is the third phase of swallowing, which speech pathologists do not look at. All right, cognition. So cognition is kind of the name of the game for this series of presentations. So I know you've heard this before if you've been following along, but I'll really briefly just go into each of these areas of cognition. So attention, right? Attention is focus, right? There are different types of attention. For example, we can talk about sustained attention, which we frequently call concentration. We can talk about selective attention. Can you tune out internal or external distractors like background noise or worry, which would be an internal distractor? Things like alternating attention. So can you switch between tasks and keep the right kind of attention on each of those things? And then things like divided attention. So can you drive and listen to the news, for example, or can you drive and have a conversation and still know where you're going? We can talk about memory again in different ways as well. Memory is really learning and recalling, right? So there are different types of memory, short-term memory, right? There's long-term memory, so things that happened in the past. We can talk about working memory, which is holding things in your mind for a few moments or while you're processing them. And then there's also things like declarative memory and procedural memory. So procedural memory being the memory of how to do something like ride a bike or drive a car. We can talk about perception. So perception is really perceiving things, right? Where things are in space, where you are in terms of sense of direction, mental imagery, those kinds of things. Processing speed is how you're able to take in information and figure out its meaning and what to do next. Okay, we can talk about reasoning and problem solving. So really evaluating, making a choice, or figuring out what to do in a situation. We can also talk about language as a cognitive function. And so that's really where the overlap is here. Language, again, being expression, comprehension, word finding. And then we can talk about executive functions. So executive functions are really the boss functions. It's being able to organize your cognitive processes in order to get things done. Okay, so executive functions include things like planning, organization, being able to prioritize, the ability to stop and start what you're doing, to self-monitor, so pay attention to what's going on, and then also being able to shift your attention between different things. Okay, so we are going to talk really briefly about Parkinson's. So this is an image of dopamine at the top. And dopamine is one of the most important neurotransmitters that we have in the brain. Dopamine is responsible for sending messages, okay, throughout the body, so brain to body. So Parkinson's disease occurs when there is a loss of the cells that produce dopamine, okay? And the results of that can be seen across the whole body. The cardinal signs, or those main signs of Parkinson's disease, are things like tremor, stiffness, or slowed movement. Okay, and in that way, Parkinson's is termed a progressive movement disorder. The interesting thing about Parkinson's is that Parkinson's is more than just what we can see, right? So more than just motor symptoms like the tremor, the stiffness, the slowed movement, right? It's also non-motor symptoms. So the things we can't see. So there are changes in Parkinson's to what we call autonomic function. So things like bowel movements or constipation, looking at blood pressure, mood, and so on. The interesting thing about Parkinson's is that those motor changes, so the tremor, the stiffness, the slowness, work the same on our speech and swallowing muscles as they do for the rest of your body. Okay, so with all of this combined, so those motor and non-motor symptoms, we often refer to Parkinson's as a whole body disease because it really does affect you in every aspect of your life. So I really wanted to quickly touch on the Canadian guideline for Parkinson's disease, which was last updated in 2019, which is basically a list of guidelines for how best to assess, treat, and manage Parkinson's disease. So speech pathologists work on a team along with your neurologist, along with your physio, your occupational therapist, a social worker, the nurse, you name it, to provide whole body care, right? Because it's a whole body disease. So in this guideline document, they do say speech and language therapy is essential to the quality of life in people with Parkinson's disease. And it should be offered to folks who are experiencing any problems with communication, swallowing, or saliva. I didn't put it on here, but they also say early intervention is the best. All right. So why talk about communication and swallowing? The fact of the matter is communication changes are really prevalent in the Parkinson's population. So lots of research shows that between 80% to 100% of folks with PD will experience communication changes. So that's things including changes to your speech. So is it slurred, for example? Is your articulation clear? Changes to your voice. So is your voice breathy or hoarse, for example? As well as language changes like word finding difficulty. And we know as folks working with Parkinson's that the psychosocial impact of communication changes is really high. So lots of the people that I work with tell me that they are withdrawing from what they previously loved or enjoyed doing because they feel they can't communicate in the same way, or they're not able to contribute in the same way, or they're speaking less on the phone. Okay, so we know that communication is central to life, right? It's central to your identity. It's central to maintaining relationships. So when there is a change, it's really impactful. Okay, in terms of swallowing, numbers vary based on the stage of Parkinson's. Okay, so some of the research that I looked at shows that up to 95% of folks with PD will have swallowing problems. Okay, we know that swallowing problems are really underreported by folks with PD. Okay, so this one study by Kath et al. In 2012 showed that only 35% of folks with PD interviewed thought that they were having swallowing problems, whereas when they were evaluated by a speech pathologist, it was found that 82% had or met the criteria for what we would call swallowing problems or dysphagia. One of the most important things about swallowing is that swallowing disorders or changes are an important risk factor for aspiration pneumonia. Okay, aspiration pneumonia is when food or liquid goes down into the airway and then into the lungs because airway protection isn't working as efficiently or effectively as previous. And whether it be because of bacteria or other factors, it causes a pneumonia. Okay, and we do know that aspiration pneumonia, unfortunately, is one of the leading causes of death in the Parkinson's population. So it is a really important factor and something to watch and manage. Okay, I hope you're all doing okay and you're still with me. We're going to move on to some common communication changes in Parkinson's. Okay, one of the first ones that people report is quieter volume or difficulty changing their volume. Okay, I do often hear patients come in with their spouses and they say, everyone says I'm speaking too quietly, but I think they just need their hearing checked. I am speaking the same volume that I always spoke. I'm sorry. While hearing loss is always a possibility, especially as you age, we know from lots and lots of research that your base volume gets turned down in Parkinson's. So you really aren't speaking as loud as you used to. And because that area in your brain, the basal ganglia, is important for feedback, you don't notice that you're a lot quieter than you used to be. All right. We also see a lot of what we call imprecise articulation. Often patients will describe that to me as mumbling or slurred speech. Okay, but it's as a result of not moving your articulators, so those muscles important for speech, as much as you used to. Okay, we also hear and observe changes in voice quality. So folks having a breathier sounding voice or more hoarseness. Speech can become monotone. Okay, so less melody or pitch variation when speaking. Sometimes it can be difficult for people then to tell if you're asking a question or making a statement or conveying emotion in that way. We know that rate of speech can change. So sometimes I see patients whose speech gets really, really fast. And on the flip side, I can see speech that gets quite slow. Okay. Difficulty initiating speech. So that can be akin to freezing when you're walking or difficulty getting started. You can see some disfluency, so what's often described as stuttering or repeating. So palilalia, repeating of words. Decreased facial expression. So I put this in here because nonverbal information is really important in communication. So when there is a decrease in facial expression as a result of Parkinson's, it can be hard for your communication partners to read your nonverbal language and understand the intent behind your speech. And then word finding difficulty. Okay, I did note here on the bottom, sensory feedback is impacted. And that's what I was really talking about with the awareness of changes to your communication being affected by Parkinson's. So folks not being aware of these things happening, although other people are telling them that they are. Okay, so swallowing changes in Parkinson's. So some of the things we see are slowness. Okay, so again, that cardinal sign of Parkinson's, that slowness, right? So slow eating or drinking or increased meal times. Sometimes we see people pocketing food. Okay, so food not being completely cleared from the mouth. Some difficulty controlling food or drinks. So sometimes you'll see food or liquid might fall from the mouth, for example, if the mouth is not being closed. Slowed or less efficient chewing or moving food around your mouth during that oral phase of swallowing, that first phase. We can also see difficulty starting a swallow. So sometimes this gets reported to me as I'm chewing, I'm ready, but my swallow just won't go. It won't start. Okay, that's really what we mean here. Food feeling stuck. Okay, sometimes people report that food feels stuck in their mouth or in their throat, like it hasn't gone down all the way. Changes like coughing, throat clearing, or choking, which can be signs that food or liquid is going the wrong way towards the airway. Okay, drooling or excess saliva, and then difficulty swallowing pills. So some of the things we often ask about when someone is having swallowing problems are things like, are you having recurring pneumonias or chest infections? Have you experienced weight loss, or are you eliminating foods or avoiding foods from your diet? All right, and just a plug for speech language pathologists, if you are experiencing any of the signs or symptoms discussed on the previous slides, please do ask for a referral to a speech language pathologist for assessment and then any treatment or management options that result from that, okay? All right, cognitive changes. So as Dr. Hanel outlined in her talk, cognitive decline can be linked to both changes in brain signaling as well as changes in brain cells themselves. Okay, so I'm not going to go into details here. Please refer back to her talk for more information. But basically, we see both what's called mild cognitive impairment in the Parkinson's population, as well as dementia. Okay, an important caveat is that cognitive changes can occur for numerous reasons. Okay, so it is important to rule out other causes of cognitive changes, which I will really briefly discuss on the next slide. So some of the changes that we might see in the Parkinson's population can include things like difficulty with memory, so trouble remembering appointments or forgetting to take your pills. Okay, things like attention, so difficulty focusing on a task or focusing on a conversation, getting distracted really easily, having a hard time filtering out internal or external distractors. Changes to processing speed, so things like listening to a conversation, but needing extra time to understand what's being said and then extra time to formulate your response. Okay, changes to things like executive function, so trouble solving problems or planning a route, deciding what to do from a list, coming up with solutions to problems. Perception can change as well, so again, planning a route or having difficulty walking. So oftentimes people will bump into a wall, for example, or get lost. And then language again. So language changes can be difficulty with word finding in a conversation, or difficulty with comprehension, difficulty starting speech or getting your words out. And then we know that cognitive changes impact speech and swallowing. This was back to my caveat slide, so cognition can change for many reasons. These are just some of them. So it's important to be aware of these and for your doctor to rule out any of these things before looking at whether cognitive changes are as a result of an actual change in cognition. Okay, so some of those other factors that can affect cognition are things like acute changes, so an infection like UTIs, for example, or something like a TIA or a stroke. Stress and mood, so depression can impact your ability to think clearly or process. Aging in general, looking at things like lack of sleep. If you've been up really late or up all night or not slept well, that'll impact your thinking and how you're able to deal with your day. Hydration. So I know Lisa, the occupational therapist, spoke about this in her talk, but hydration is really important to keeping our brains sharp. Other things like other diseases, so chronic diseases such as diabetes can impact cognition. Medication or side effects from medication can impact cognition. And then things like hearing loss and vision changes. So I often remind or encourage my patients to wear their hearing aids because you're really missing out on the world around you if you're not hearing things. And it's very easy to miss parts of a conversation or miss the context and so on if you're not listening optimally. Okay. The other thing is vision changes. So it's important to be able to see and address any changes to vision like blurry vision, double vision, or just progression in your prescription to make sure that you're able to interact with the world around you. All right. I am going to pause and take a quick drink. As a speech pathologist, I will use this opportunity to tell you that having a drink, keeping yourself hydrated is really good for your voice and just good vocal hygiene in general. So please also take a drink or have a snack if you would like to. Okay. So I thought it might be useful to show some of the different areas of cognition and then how they might affect communication or swallowing / meal times. So for example, attention. An impact of a change in attention on communication could make it difficult to multitask or divide attention while speaking. Or somebody might become really easily distracted during a conversation and miss parts of what's been said. Attention and the way that it can impact swallowing or at meal times. Sometimes people will have difficulty focusing on their meal, okay? Especially if there are distractions around. So prime example is too many people talking at the dinner table, having the TV on and trying to eat and focus on your meal while watching TV. Even things like having too much on a table can be distracting for somebody. Another way attention can change is just the awareness of food in the mouth. So sometimes we'll see with cognitive changes that people aren't aware that they already have food in their mouth and they haven't swallowed it. Memory, so possible impact on communication. So someone may not recall a conversation or the topic you're speaking about. Okay, they might have word finding difficulties, difficulty recalling phone numbers or instructions. Okay, and then in terms of swallowing, difficulty remembering to use a swallowing strategy. So especially if you've seen a speech language pathologist and we've recommended something to keep you safe, if you have memory changes, it can be difficult to implement that. Okay. In addition, forgetting meal times in general. So forgetting to eat or forgetting when you last ate. And then difficulty with the steps of eating. So remembering you put it in your mouth, you chew it up, and then you swallow. Okay, processing speed. So as mentioned on a previous slide, it can take extra time for somebody to understand what is being conveyed to them, or take extra time to respond. Okay, they can get stuck on a previous topic, have difficulty switching, right? Which can also be part of attention. And then they might also need repetition because their processing speed has become slower. Possible effect on swallowing would be things like slower response time to a verbal cue, like swallow, okay? Or a slower response time to food being offered. Okay, so the food might be there, and it's just taking a little bit longer for them to take the food or begin the process of chewing and so on. Executive functions, so difficulty with decision making, planning a discussion or what to say, staying on topic, or losing your train of thought can be possible effects on communication. And then possible effects of changes to executive function on swallowing or at meal times can be things like impulsive eating or stuffing your mouth full of food even though you haven't swallowed yet, or having difficulty slowing down when you're eating. Okay, so that was a lot of information. So now we're going to talk about some strategies. Okay, it's important for me to note that everybody is different, right? Parkinson's affects people in different ways at different times. So some of these strategies may or may not work for you or for your loved one. So I would encourage you, as always, to speak to your team. So especially here, your SLP, your speech therapist, or your OT, for example, about some of these strategies. All right. So first, I want to talk about communication, and I have a few slides on communication because there are lots of different ways that we can support communication in terms of being understood, in terms of the way we set ourselves up, and so on. So first of all, I always like to say, set yourself up for success. Okay, so setting yourself up for success means taking your environment into consideration. Okay, so a really important one is reducing background noise. Okay, so turning off TVs or radios, anything competing or providing audio or visual information in the room. Reducing distractions, same kind of thing. It's not enough just to mute the TV. Turning the TV off in general is important because somebody could still be watching the TV on mute even though they can't hear it. Okay. Thinking about the setting size. So are you in a group setting versus a smaller one-to-one setting? Folks who are experiencing changes to communication and cognition often do better in a smaller setting because they're not overwhelmed by many different conversations going on or trying to keep up with different conversation threads. Okay, it's important to have good lighting, okay, and facing each other so that you can make eye contact. We take a lot of information in non-verbally from our communication partners that help us understand. So when you're in separate rooms trying to talk, somebody has changes to their speech, and you're not looking at each other, it's going to be harder than if you're facing each other, have good lighting, and can see. Okay. It's important again to have hearing aids in place and on, to have glasses on so that we're using all the tools possible for good communication. I wrote here, making sure it's a good time. So lots of times we might not think about how someone is doing during the day or how their energy might be changing, right? Lots of times with folks with PD, paying attention to how they do in the morning versus at night can inform when you have a conversation or make a phone call, okay? Or do they do better right after they've had their medication? Okay, using that information to choose a good time to communicate so that you're, again, setting yourself up for success is important. I did also put on here having communication or conversation aids or visuals if needed. Okay, that means things like having pieces of paper, a pen, or pictures, being able to point to the environment around you as another way of communicating your message. Okay, in terms of how you say it, okay? So when you're speaking with somebody who has had changes to cognition, there are some ways to change what you say and how you say it to promote understanding. So it's important to give context, okay? Meaning introduce the topic. If you're shifting topics, say, we're done talking about dinner, let's talk about your grandkids. Okay, so alerting people that you're shifting conversation topic can give them time to process that, okay? It's important to try and simplify the message you're saying. Okay, so there are lots of ways we can simplify what we say, doing things like speaking in shorter sentences, okay, saying things slower, but not too slow, okay, and using a normal volume, okay, not being overly loud, okay? Being direct, but kind. So what I mean by this is sometimes when we need to have a difficult conversation, we might use analogies or metaphors to beat around the bush, so to say, right? Adding in analogies or metaphors can be confusing. So it's often a lot easier to say things more directly and to the point to support understanding, okay? If you're needing to ask questions, doing things like using yes or no questions, like, are you hungry? Yes, no. Or providing simple choices. So, for example, do you want coffee or tea? Instead of an open-ended question. So something like, what do you want to drink? Okay, that narrows down the possible responses for someone, making it easier to actually focus in on what to say. I have on here using proper names versus pronouns. So what I mean by that is actually addressing a person's name if you're talking about someone else. So for example, saying your grandkid Joe versus saying he, right? So by using names more frequently, you're supporting someone's understanding or processing about what you're talking about, okay? Using he, she, and so on can get confusing if there are multiple reference in the story, okay? I also put on here, break it down. So if it's something long or you're giving instructions, instead of giving all the information at once, break it down into steps, make them really clear, okay? Provide them one at a time. I also have say things in more than one way. So don't be afraid to use the environment to your advantage. So oftentimes using pictures or objects or even pointing to things around you can support comprehension, okay? Gestures, writing down keywords can be a huge help. And by that, I mean, when you're talking about something, choosing only the main points, not writing down everything you say, but just who it's about, the plan, and the important things. So, you know, if you were reading this, what you would highlight, okay? You're not going to highlight the whole thing. All right, so then I have memory tools, and I will chat about that in a little bit. I also wanted to add, actually, try not to speak for someone else unless you have their permission or if they want you to jump in and help. It's important to know that we can support independence and support participation in lots of different ways that aren't taking over or speaking for someone. And in that way, you're honoring their competence, okay, and their ability to participate. Sometimes asking if they want help or coming up with a signal between the person with Parkinson's and the care partner or communication partner can be a nice way to do that if you're out in public. Okay, so sometimes people will do like a little thumbs up or like nod if they want you to take over. All right. Okay, so some other ways to support understanding or comprehension when somebody is experiencing cognitive changes. Number one is being patient. Okay, providing time for them to process and time for them to respond. Okay, confirming understanding. So, did you get that? Do you have any questions? Things like that. My lights went off. Doing things like repeating your message or rephrasing or summarizing. Those can all be good ways to confirm or support what you're talking about, okay? And then referring to keywords if you've written them down. The cool thing about writing on paper is when something comes up again, if somebody's forgotten and you still have that paper, you can refer back to it. Again, breaking down longer messages. And then I did have on here, paying attention to hearing and vision. Okay, listen closely, not just with your ears. So I'll go through this pretty quickly because some of it is repetitive, but being an active listener, paying attention to body language, eye gaze, intonation, and context, as well as word choice. Being honest if you didn't understand someone. So asking them for repetition. Can you say that again? Or clarification, right? I didn't quite get that. Did you say X, Y, Z? Or confirming, like, I think you said you want steak for dinner. Is that right? Or even having them repeat only the part you didn't get. So you want what for dinner instead of what did you say? Because that breaks down or lessens the amount that they need to repeat. Okay. Using confirmation of what you heard, I already said that one. Being open to and encouraging people to use their strategies, especially if they've been working with a speech therapist or an OT or other ways that they have to communicate. So if they need to use a notepad because they're having a bad speech day, for example, or they use what's called AAC, so an augmentative or alternative way of communicating. So something like a voice amplifier, or if they're using an iPad with an app to support communication, be open to that and encourage it. Lots of times that means more patience. Okay. Be encouraging and respectful. Know when to take a break, especially if emotions or frustration is really high. And then don't demand perfection. So sometimes we can get hung up on things being delivered in a perfect way, right? But the truth is we understand a lot, even if some of the words aren't clear or the sentence was short and so on, okay? It just needs to be good enough that you understand. For my folks out there with PD, some of the Good strategies are doing things like slowing down, take a deep breath before you speak, okay? Exaggerating your articulation, increasing your volume, saying things in less words, okay? As it takes less energy, using other ways to communicate, using word finding strategies, confirming your communication partner understood you, and then taking breaks when you need to. If you're tired, your speech is probably going to be harder to make clear, and it's okay to come back to things later. Okay, swallowing in meal times. So similarly to communication, you want an environment to be optimal, okay? You want it to be quiet and calm. You want to reduce distractions. You don't want to hurry someone, okay? I have on here, consider energy conservation. So if something is taking a really long time to eat, or it takes a long time to finish a meal, consider things like having smaller portions at a time, or eating more frequently, or talking to a speech pathologist or a dietitian about ways to modify food so it's not so effortful. Okay, sitting at eye level is always a good strategy. Providing visual or verbal cues, so swallow or chew, or actually showing someone how to eat can help trigger that memory. Reducing bite or sip sizes, again, something you can speak to an SLP about. Encouraging somebody put their cutlery down between bites, especially if they're eating impulsively or really quickly, can help slow things down. If you're providing feeding support, watching for a swallow before providing the next bite, and always checking the mouth for residue. A few other things, supporting oral care. So oral care is one of the best things we can do to reduce the risk of aspiration pneumonia. So supporting someone in having their teeth brushed, their tongue brushed, their dentures cleaned before or after a meal is a great option, or not a great option, but it's a great thing that I encourage you to do. Staying upright for 30 minutes is always a good idea, just to help make sure that food goes down the way we want it, instead of the potential for it to come back up through reflux if you lie down pretty quickly after eating. Monitoring weight intake, signs or symptoms of aspiration, so things like coughing, choking, throat clearing, as well as signs of pneumonia. I have on here, incorporate wishes and choices where possible into meal times. So what I mean by that is if someone is having changes to their preferences, try and incorporate some of those things into meal times where possible. Talk to a dietitian or a speech pathologist if you have more questions about that. Avoiding force feeding. We put this on here just because sometimes we get very concerned about people losing weight or not eating enough. And we think we're doing the best thing for them by trying to get them to eat. But if people don't want to eat, sometimes that can be riskier because it can put them at risk for choking or coughing on something. Learn what to do in an emergency. So I encourage all of my patients and caregivers to know what to do in the event of choking, for example. You can look, if you Google search choking adults Red Cross, some really good handouts and videos come up immediately, and I would encourage you to look at those. When in doubt, always call 911 if someone is choking. Okay. Pay attention to timing, so timing of day and fatigue, as well as medication timing. And then I have on here, find other ways to celebrate. So if meal times have become difficult and swallowing problems are a big issue, try and find other ways to celebrate life events like birthdays or anniversaries that don't revolve solely around food, so that somebody can feel like they're still participating while we eliminate maybe some of that challenge or embarrassment with difficulty around eating. Everyone is different, okay? So a lot of these strategies might be part of what's recommended to you along with specific postures or maneuvers or recommendations from a speech pathologist based on a specific evaluation of swallowing. All right. Whew, I'm running out of time here, but I really quickly want to talk about some strategies for daily life, because these pertain to a lot of what we just talked about in terms of communication and swallowing, as well as cognitive communication. Okay, so we're going to talk about routine first. Don't underestimate the power of routine. Okay, so routine is a wonderful thing because it means your day is predictable. You know what to do. It gets rid of some of that uncertainty about how to get through a day, but also provides structure for somebody who might not remember what to do every day. So lots of ways to encourage routine. So checking things off. So having a list of normal daily activities that someone can check off. So you might laminate it and use a whiteboard pen, for example. Using a big monthly calendar and crossing off days. Using planners, a whiteboard for important reminders, or notebooks. Having a place for everything and everything in its place. So what I mean by that is making sure you have somewhere to put things, where people know where they go and where to find them. So there's no guessing or looking for things. Habit stacking. So habit stacking refers to when you have a habit in place already, like brushing your teeth. So when you find yourself with something else you need to work on, like flossing your teeth or doing your voice or swallowing exercises, thinking about doing that right after a habit you already have in place can decrease some of the cognitive load there and make it a little easier to do. Routine can also really support independence. Okay, reminders. There's lots of ways to incorporate reminders in your day-to-day life. So creating and keeping lists for common things. So lists that you use again and again. For groceries, or lists of phone numbers that you keep somewhere so you don't have to remember them. Sticky notes or whiteboard markers. So I will often encourage my patients to put sticky notes up on the mirror in their bathroom or on their front door, or even in the kitchen by the stove. Turn off the stove, for example, or don't forget your mask, wallet, keys, walker on the door. But I also really like whiteboard markers. So you can use whiteboard markers on your mirrors, for example. So if you need to remember something in the morning, or even your morning routine, right? Like brush teeth, speech, or swallowing exercises, you can do that, okay? Then alarms, smartphones, watches, and what a time timer. So alarms can be great. You're outsourcing having to remember something to something else, right? A time timer is actually what I have a picture of here in the corner. A time timer is a nifty little timer that you can get that instead of showing you how much time has passed, it shows you how much time is left. So for example, I have one right here. It's been counting down how much time I have left in this presentation. Okay, so it's a neat way of just visualizing that can help lots of people see how much time is left to do something before they need to switch tasks. Notebooks. So I like notebooks for lots of things. Having a daily diary, writing down what you did in a day, for example, so you can look back at it. For your lists, I encourage people to have one notebook for lists so you don't have sticky notes or pieces of paper everywhere. Again, you always know where to look. Having one by the phone is a great option to record appointments or messages. Labels. I believe Lisa mentioned this, but labeling things around the house. Okay, so you know what they are and where things are, and then color coding can be great as well. All right, I only have a couple more slides here. This is one of my favorite things to encourage patients and caregivers to set up. And it's called the orientation station. So an orientation station is really an area in your home that is the go-to spot with information about the day, the month, the time, the year, okay? So it can include a monthly calendar. and you can cross off the days as they pass so you can easily see what day it is. A whiteboard where you can write, again, the date, any appointments for that day, or the daily routine where it can be checked off. You can also have things like important contacts on a list there, a digital clock, big, easy numbers to read. Having the date on there can also help, and so on. You want it to be easy to read and easy to understand. And then sometimes it's also helpful to have photos of your family and friends. Okay, so you have something positive to look at. Okay. I also like something called the launch pad. So a launch pad is basically a designated place for everything you need when you do something specific, like you go to leave the house. So essentially, you would have your keys, your purse, your mask, your mobility aid, maybe some emergency contact information and note reminders in this one place. And the trick here is you always put those things back in this one place so you know they're there when you need to leave. You can also adapt this idea to other areas of the house. Okay, so having everything you need in one spot. Memory books. This is something I really like because it can serve as a communication support or can be used in reminiscing, so talking about the past. But essentially, a memory book is something where you have an About Me page. So where someone was born, their job, their family, their accomplishments. You can put hobbies and interests in there. It can also be a nice memory support for family members and their names. So having their picture, their name, and then maybe a fact about them, like where they live or what they do. And then also emergency contact information in there. Technology. So technology can be a wonderful thing, but it can also be a scary thing. But the neat thing about technology is that it's advancing in ways that can be used to support independence and functioning in the home for people with a variety of needs. So I've already mentioned alarms, so using them on clocks or on smartphones or watches. But my number one thing about using alarms like that is the importance of learning snooze versus turning something off, right? If you can't take your medication right now, snooze it. Don't turn it off. Otherwise, it's not helping, right? You need to snooze until you do it, okay? Voice activated technology is things like Google Home or Alexa or Siri. Okay, so those are things that you can actually program to tell you the weather, tell you upcoming events, control the environment around you, like playing songs or calling someone even for you. There's also things like setting reminders on phones, so calendar pop-ups to come up, or you can put appointments in phone calendars. And then of course, there's using Zoom or video to maintain social connections. There's lots of neat options for technology. Okay, my very last thing, because I know I'm pretty much at time here, is just to make sure that you stay active. We talk a lot in education for folks with PD about the importance of exercise, but exercise is not just physical exercise. Okay, exercise is also cognitive exercise. Okay, it's also linguistic exercise. It's keeping yourself participating in things that really work your brain, work your communication. So I do have a list of things here that you can do to incorporate more cognitive or linguistic stimulation in your day-to-day life. All right, you can read those when the slides are posted. Okay, I am done. Thank you so much for being attentive listeners. I am happy to answer any questions if there are any.
Jamie, I'm just looking at the chat box right now, and
Yeah.
There's no questions yet, but we can give it a couple of minutes.
Sure.
So again, you can write your comments or questions in the chat box. And we'll wait a couple of minutes and then we'll wrap things up if there's no questions.
Sure. Oh, I see one in there. What are some word finding strategies? That's a great question. Um, Word finding strategies include things like gestures or pointing to things in the environment to support finding a word or communicating what you're trying to say. It can be things like talking around a word. So often when I'm working on that with folks with PD, I'll encourage them to describe something, right? So if you're trying to think of the word for apple, you could say it's red, it's a fruit, it's round. You can even say grow on trees, things like that. So talking around it. If you can't think of the word, but you can come up with a synonym or an antonym. So a word that's similar or a word that has the opposite meaning, that can be helpful too. So if you're thinking of the word day, you could say it's not night, it's, and someone can help fill that in. If you're the communication partner and you know the word that they're trying to say, instead of saying it for them, if appropriate, you can also offer cues like giving them the first letter or the first sound. So sometimes providing those things can help someone trigger the memory of that word and help it get out. It's a great question. I'll actually, I believe it was Diane who asked that. Diane, I'll actually put some word finding strategies in my presentation so that when it's posted, I'll have a list of those there for you too. Alana, were there more questions?
So a few more questions.
Okay.
Are you taking referrals for new patients? How long is your wait list? We live on Vancouver Island.
Okay. So I am only working in public health here in Fraser Health, but there is a movement disorders clinic for Parkinson's in Victoria, and they do have a full-time speech language pathologist there. So I would encourage you to reach out to that clinic and ask for a referral to the speech language pathologist there. Okay, I know lots of us are doing both in clinic and virtual visits. So depending on where you are, that might be an option for you.
And some comments as well. Thank you for an interesting webinar. Thanks, enjoyed your presentation. Very thought-provoking and helpful.
Thank you.
My husband is in a care home. How do I get a referral to a speech pathologist?
Okay. So that can go through the GP. Okay, so you can ask your GP or the most responsible physician for a referral to speech language pathology. Unfortunately, in public health, at least in Fraser Health, we don't have speech pathologists who will come to you. But once a referral is put in, if you're able to bring your husband in for an appointment to one of our outpatient sites, that would be an option. It would also be an option to look for private speech therapy services, because in that case, someone would be able to come out to you and him in the care home.
Thanks, Jamie. And
Yeah.
next question is, how do you clear throat when you have a food swallowing difficulty?
How do you clear your throat when you have a food swallowing difficulty? I'm not entirely sure what you're asking. So when I talk about clearing your throat, often I'm referring to clearing your throat as like a sign of things having gone the wrong way. So for example, if you're having liquids that go the wrong way and they might be entering the top of your voice box, for example, it's your body's response to think, hey, something went the wrong way. I'm going to clear my throat to try and get it out. Okay, so that's your body's natural response to trying to get something out. Victor, I'm not sure if you could clarify what you mean, but if you're meaning something like how do you clear food or liquid if you're feeling like it's stuck in your throat, like after you've done an initial or a secondary swallow, that would be a really good question for your speech language pathologist. So going in to see someone and having an assessment to see if things are getting stuck, and then if there are strategies that can help you clear that. So sometimes, for example, we can see that swallowing more than once per bite or sip of liquid can help people clear any residue. Or if you've had something dry or crunchy, having a sip of water can also help clear things, and so on. But I would really encourage you to see a speech pathologist if you haven't already. Okay.
All right, I think those are all of our questions. I want to thank you so much for putting on such an informative presentation, Jamie. Thank you so much. And thank
You're
you
very
everyone
welcome.
for attending, and thank you for your questions. And we will see you at the next webinar. Thanks very much. Bye now.
Thanks so much. Take care.